This is the Emergency Medical Minute, sponsored by Mile High Ambulance. The Emergency Medical Minute is excited to announce that we are now offering AMA PRA Category 1 credits. This is accessible through our online course modules that can be accessed at www.emergencymedicalminute.org/CME-courses, or simply by clicking on the link in our show notes and creating an account.
So this is a case of a patient that came in via EMS with palpitations. The presenting EKG is here. As you can see, what it represents is a wide complex tachycardia. So a tachycardia generally is a heart rate greater than 100. Wide complex is defined as greater than 120 milliseconds, which is 3 boxes on a standard EKG. So as far as sort of this case, before we talk about the differential diagnosis, what components of the history would you want to know in terms of helping you differentiate the severity as well as the cause of this wide complex tachycardia? And then I'll answer those and then we'll move forward. So history of coronary artery disease, knew that remotely he had PCI and some stents. No known congestive heart failure, not on CHF meds. Does not have a pacer or an AICD. And that's a really relevant question because when we talk about the differential, the main differential is VTach versus SVT with aberrancy, right? So VTach would be much more common in patients who are elderly or have cardiac comorbidities, which are either ischemic or structural heart disease. So that's really the main relevant one in terms, of cardiac history, ischemic or structural heart disease, and age. As far as defining or helping distinguish, furthermore, SVT with aberrancy, when you think about SVT, what are some of the tachycardias that you think of? So those are typically narrow complex tachycardias, but which ones are SVTs? So you can use heart rate to help distinguish it. In general, VTach is going to be faster than SVT with aberrancy, but you can have slow VTach at a heart rate of 120. So it's not as useful in terms of distinguishing. What I'm sort of getting at is SVTs are things like a flutter, and then PSVT. You can get AV reentrant tachycardias with things like Wolff-Parkinson-White. So those are typically narrow complex tachycardias, but when the rate gets high, sometimes you get quote unquote aberrancy, which is you get a bundle branch block pattern, typically in a left bundle or a right bundle branch block pattern, because the conduction system is, the rate is too high that the conduction system can't handle that, okay? So it ends up that there's a really good but somewhat elaborate algorithm that's classically used, which is called the Brugada Criteria, to help distinguish with a high degree of sensitivity and specificity. In general, this is only applicable for stable patients. Any unstable patient, whether it's SVT with aberrancy or gets cardioverted, if it ends up that, you're cardioverting someone that's relatively stable, that's generally, relatively safe as well. So this is sort of an academic exercise, but relevant in this patient's case because it was a highly stable patient and he did not require cardioversion. And we used the algorithm to define him as VTach, and he got started on amiodarone instead of SVT with aberrancy treatment, which would be things like a-flutter medications or PSVT, either DILT or adenosine respectively. So it ends up that without going through the whole thing there, simple ways that you can just sort of gestalt look at an EKG and know that it's VTach is if in all the precordial leads, all the QRS complexes are either all positive or all negative, okay? That's called concordance. And then so here, you see that it's all upright here, right? This is the QRS, this is the T wave, QRS, upright, 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 but here it's a negative deflection. So you can't use concordance, which is this first criteria. The second criteria is that the R to S interval is greater than 100 milliseconds. And it ends up that if you look here, the R wave begins here. This is the T wave, so you think of the S as beginning down here, and it's definitely more than 3 boxes, more than 120 milliseconds. So just by gestalt, looking at it, if you're really wide in V1, even if there's not concordance, then it's generally going to be VTAC with a high degree of specificity. They use a couple other criteria that gets a little bit wonky, but this sort of gives you a sense of what we do when we're assessing between SVT with aberrancy versus VTAC, and then sort of the time-honored criteria, which is this Brugada criteria, and that ended up being helpful in terms of characterizing this as a stable VTAC treated with amiodarone and subsequently chemically cardioverted inpatient. If he decompensated at all, we would add a low threshold to shock, but it wasn't necessary in this case. Cool?
Yeah.
All right, any questions?
We'd like to thank our sponsor, Health One Continental Division, and Swedish Medical Center for their financial contributions to the EMM. Donations from them and listeners like you make it possible for us to fulfill our mission of producing and spreading free medical education to the masses. If you enjoy our show, please consider making a one-time or recurring donation to help cover our operational costs and keep the EMM awesome. Click on the link in our show notes to make a donation. Thank you for listening.